We're just going to wait for people to come in. Okay, I'm going to run through the attendees' rules of engagement so everybody knows how we're going to run things tonight. This webinar is being recorded. No one can see that you're attending unless you would like to ask questions. So if you'd like anonymity during the question and answers, please tick the box to send anonymously before sending your question. We hope to make this webinar as helpful to you as possible, so please do ask your questions. Type the questions in the question and answer section. Please direct questions to the panelists only. Start with the name of who you're directing the question to. You may ask the questions at any point, but they'll be answered after all the talks. If we don't get through your questions in the allocated time, which is 1 hour tonight, we will answer them via email after the session. Please remember that this is our beloved South Africa, so if there is load shedding or dodgy internet connection, please just bear with us and we'll resume proceedings ASAP. Okay, this is the agenda for tonight. I'm going to be doing a short introduction. Then we're going to have Dr. Jack Biko from Femicare Fertility and Advanced Endoscopic Surgery Center, Dr. Michelle Redelinghuys from Merck. She's going to be talking about Merck's commitment to patient care. And Elie Kouaiky is going to be doing his personal story. We're going to have a Q&A session afterwards and we'll wrap up at 6:55. I'd like to thank all the sponsors for helping us to educate the public about infertility. Your support helps us to break the silence, but it doesn't constitute an endorsement of any product or service by IFAASA, House of Fertility, or any of our speakers. Okay. Thank you to everyone for joining us tonight as we round off day 2 of the inaugural National Infertility Awareness Week South Africa by talking about male infertility. My name is Saskia Williams and I am the founding director and CEO of IFAASA, which is the Infertility Awareness Association of South Africa. And we are bringing you this week in association with House of Fertility. IFAASA is a non-profit company that was established in 2013 to break the silence around infertility in South Africa, to educate the general public and to advocate the medical aids for fair cover for this prescribed minimum benefit disease. Some of you may not know that infertility is the only prescribed minimum benefit disease on the exclusion list of most medical aids, but we are fighting hard to change the status quo. Make sure you follow our Facebook page for the latest updates and how you can help us in this ongoing fight. Let's get started. Our first speaker is Dr. Jack Biko. Dr. Biko is a reproductive medicine specialist and gynecologic endoscopic surgeon from Femicare Fertility and Advanced Endoscopic Surgery Center. He is talking to you tonight about male infertility. Thank you, Dr. Biko.
Okay, I'm just trying to get my thing in order here. Is my slide on?
It is, yes.
Good. Thank you, Saskia, and your team at IFAASA. And also want to thank our dear friends at House of Fertility for inviting us to present this very important topic on male infertility. There will be a lot of available information shared throughout this week about infertility. And my talk tonight will be about male infertility, but I can assure you that it is more than just babies. So if we talk about male infertility, we better start by talking about what is fertility. Now, fertility or male fertility is the ability to produce and deliver by normal sexual intercourse and ejaculate containing enough spermatozoa with the capability of causing a conception in the partner at the normal rate of 20% per month. So this tells you that the chances of conceiving per month is not more than 20% in couples where everything is fine. But we're going to talk about this unspoken male factor infertility. Now, male factor is always a medical and a social blind spot because we correctly concentrate on women and their eggs, but unfortunately, we completely ignore men and their sperms. Infertility has got severe psychosocial impact on male because these guys have been shown to be totally isolated. They have difficulties in partner communication. They actually have active avoidance coping styles. And unlike with the women partners, they prefer to receive their support from us directly, the fertility specialists, rather than going to a psychologist or to friends or to go to support groups. So men do not like to go to support groups to discuss their problems there. They are more comfortable with the doctor and the doctor to explain everything to them. There are other problems that are associated with infertility, other medical problems. We know that the risk of developing diabetes mellitus is up to 30%. The risk of developing heart problems is up to 50%. So once a guy has been diagnosed with infertility, there are bigger problems that we have to worry about. And if nothing is done about them, these guys will be in trouble in terms of chronic medical illnesses. They also have got a 19% higher risk of developing depression and a very high risk of abusing drugs if no treatment is provided. So let us just clarify a few things before we go any further. There are some misunderstandings which really have to be clarified right in the beginning. First of all, fertility does not imply potency. And in the same vein, infertility does not imply impotence. So infertility does not equate to low levels of virility. So it is extremely important that when we test these guys, when we do a semen analysis test, we have to make it clear that we are testing the sperms and we have to inform them that this is not a test for your virility or for your potency. It is a normal test like a diabetes test. It is just to check the sperm number, the sperm function, and stuff like that. So now let's come to the causes of infertility. It is very important to understand that the male contribution to the problem of infertility is as big as the female's contribution to the problem of infertility. Infertility is truly a couple problem, not an individual problem. As you can see in this diagram here, the male contributes up to 66% of infertility and the female about the same. So I drafted this diagram to explain what a very important point that I want to make is that if a male is fertile, everything is fine in a male, and the female is the same, everything is fine, they will conceive, there'll be a pregnancy. If the male is fertile and the female is subfertile, they will probably conceive because the male will sort of micromanipulate that such that they can overcome the small problems of the other couple. So if one of the couples is subfertile and the other one is fertile, there is probably going to be a pregnancy. But if both the male and the female are subfertile, then the chances of them conceiving is still there, but not as great as if one of them was completely fine. So the only time when it's going to be difficult for a couple to conceive, when it's going to be almost impossible for a couple to conceive using their own gonads or their own gametes, will be when one of the members is totally sterile. By sterile, we mean that there are no eggs or there are totally no sperms. That is the only situation whereby they might have to require egg donation, sperm donation, or embryo donation. Now there's a crisis, and it's called a male infertility crisis. Now, a number of studies have shown that the proportion of normal sperms in men has declined significantly over the years. Now, we know that the goalposts or the means in which we measure the morphology has changed over the years, but despite the change in the measures, there has been a decline in the proportion of normal sperms. In fact, many folks do not know that in an average normal male person, only about 4% of our sperms are normal, and up to 96% of our sperms are abnormal, and that is regarded as normal. Levine et al. In their publication show that in the last 40 years, there has been a 52% decline in sperm numbers. So our sperm counts have declined significantly over the years. Now, all these studies were done in the Western countries, and this decline has been shown to be happening in the Western countries. But there are more publications available which show that even in the countries in Africa and in South America, there has been a decline in sperm parameters, although the decline is not as high as in the Western countries. So there is a decline in sperm parameters, whether it's sperm numbers or morphology or the movement of sperms. So why this crisis? Why do we have a male infertility crisis? Well, there are a number of factors. Firstly, our lifestyle. We are smoking, and smoking contains nicotine. Nicotine impairs the sperm function. It damages the DNA. It makes the sperms move less. It makes the sperms to look abnormal. It affects the morphology of sperms. We abuse alcohol, and alcohol can cause sexual dysfunction. We are overweight, we are fat, and we are very tight. We dress very tightly, and squeezing all our testicles is not healthy for sperm production. And there's a big concept of chemicals, and we'll briefly talk about endocrine disrupting chemicals, because this brings a lot of changes to the whole outcome of human life, I think. And then there's poor health, such as uncontrolled diabetes mellitus and poorly controlled hypertension, which will affect our sperm parameters. Now, body habitus is a big problem. Obesity is a major problem in Africa and in America, in some European countries. Now, if we are fat, the fat contains certain aromatase enzymes. What those enzymes in the fat do, they convert the androgens, the male hormones, into female hormones. So if we are this fat, we've got more female hormones than we have got male hormones. And as such, we develop breasts. You see men developing breasts. And the high levels of estrogen in the testicular environment cause abnormal production of sperms, and therefore we're going to have low sperm parameters. And the high estrogen levels as well will cause sexual dysfunction. So the lifestyles that we lead to long-term problems in terms of reproduction. But sometimes as boys, we are born pre-polluted. Our mothers smoke during pregnancy. Some use substances. And importantly, malnutrition during pregnancy has been shown to affect the reproductive outcome of those boys. And as we said earlier on, exposure to environmental toxin will have a negative impact on our reproduction. Now, what are endocrine disrupting chemicals? Now, these are generally man-made chemicals. that we use in all sorts of products in our household, that we use as pesticides. The problem with these products is they are endocrine disrupting. They disrupt the normal mechanism, the normal way of action of the various hormones, and therefore leading to various problems. And the problem with these chemicals is that they affect 3 generations at once. So if the mother is affected, if she ingests these chemicals and she's pregnant, those chemicals will go to a baby, or unborn baby. And those chemicals will reach the gonads of her unborn babies. In other words, they will reach the spermatogonia and the eggs of the unborn baby, such that the unborn baby is going to be affected, and the baby of the unborn baby is going to be affected from the chemical used by the mother. And because of that, we're seeing this problem of feminization of boys. Because most of these endocrine disrupting chemicals, they block the formation of male hormone androgens. They act more like female hormones. Now, this is a beautiful publication that was published about 2-3 years ago, which shows that all these chemicals that we use, the smoking that we do, the lifestyle, and various genetic factors contribute together to cause impairment of all the cells in the testicles. So the testicles got a number of cells, germ cells, Sertoli cells, Leydig cells, and lots of cells. Now all of those cell lines are damaged. And when they get damaged, we get abnormal formation of external genitalia of the boys. Often the testes are undescended. They get low sperm parameters. We get abnormal or low production of male hormones, and unfortunately, we got increased occurrence of testicular cancers. In fact, if you look over the couple of years, there has been a significant decline in sperm parameters, and over the same period, there has been a significant increase in testicular cancers, which tells us that these 2 things, they started prenatally. Whatever was used prenatally is damaging our sperms and it's increasing the risk of the boys developing testicular cancer. All right, so now let's come to the topic itself, the male infertility. Why is there a problem? Why do guys not have babies? Well, in layman's term, either if there's no sperm production, then there's going to be no baby. Now, for sperm production to happen, we need the brain to send messages to the testicles for the testicles to produce sperms. So we need the brain and the testicles to be functional for adequate sperm production. The second problem could be the sperms are not delivered to the right place. So there's a problem with the sperm tubes. So either the tubes are blocked, or the sperms took a wrong turn. Instead of going into the vagina outside, they went into the bladder, took a wrong turn. Thirdly, either the sperm function is abnormal or the sperms themselves are abnormal. In other words, they don't look good, they're not dense enough, so they can't fertilize any egg, or they just don't move too quickly, or they don't move well, or they move in circles, they don't move forward, or the testes are too hot because of various things like varicoceles and stuff like that. And finally, the final cause of infertility could be sexual dysfunction, impotence, and stuff like that. So how to approach a male with infertility? Well, we take a good history. Developmental history, want to know how did this guy develop from the time they were born? Were they born with the testes outside or were they inside? When did the testes descend? You get a full family history. And then we examine the guys. And then after a full general examination and a specific testicular examination, and then we will do a semen analysis, a sperm test. Remember we said that a sperm test is not a measure of manhood. It is just a test for fertility. Depending on what we find on the sperm test, we may then do hormone profile and other tests. And then we may decide to offer certain treatment, either surgical treatment or medical treatment to improve the sperm parameters. So once a sperm test has been done, we're going to get the results. And this is one of the biggest problems that we experience as fertility specialists, because there's a huge problem amongst the doctors and the specialists, the gynaecists, and the urologists. People are struggling to interpret the semen analysis. And it gives the guys a very bad impression sometimes about the doctors, because we interpret this thing wrongly. So briefly, what we have there, which is circled, is that those values which are there are normal values. Those are values of men who could conceive or create a conception within 1 year of sexual intercourse with their partners. And this is the sperm count in those men was 15 million sperms per mil. And I want to go to the bottom part there. The percentage of normal sperms was 4%, like we said it. So in patients whose sperm count, whose morphology is 4%, in other words, if only 4% of your sperms are normal, that's regarded as normal. So this is just a value of the sperm count as to what are the normal guys. These guys could get their wives or their partners pregnant in 1 year. And the bottom line is 1 year. So with those parameters, you are most likely going to be possible to get your partner pregnant in 1 year. So like we said, that the sperm analysis is not a measure of your manhood. There are guys with totally abnormal sperms who will get their wives pregnant within 1 year. Then there are those guys with totally normal sperms who will struggle to get their partners pregnant. So the sperm test does not necessarily mean that you cannot get pregnant. So what an abnormal sperm test means, so if the sperm parameters are abnormal, it simply means that the time to conception may be more than 1 year. So it may take longer than 1 year for a patient with an abnormal sperm test to conceive, when it takes about a year for a guy with a normal sperm test to conceive. So an abnormal result doesn't necessarily mean that the guy is infertile. So human sperms, like we said, are not great. Up to 96% of our sperms are abnormal, and that is normal. Human sperms have high DNA damage, and as a result, we have high birth defect rates. Okay. There's a high pregnancy rate because of the high aneuploidy rate, and as such, we have a low fertility rate of about 20% per month. The human reproductive system is the most inefficient system in humans, and thus the high incidence of infertility and the way we struggle to get our patients pregnant, because our system is very, very inefficient. All right, so now when do we do blood tests on patients? Well, we do hormone profile in male if the sperm count is very low, less than 10 million, if there's impaired sexual function, or if there are other clinical indications for that. And what we normally do is the FSH, the LH, and the testosterone, and as well as the prolactin. You should not ignore the prolactin test. It's important to measure the prolactin in male with infertility. Now, as we said earlier on, the factors that affect production of sperm is the brain and the testes. So if there's no sperm in the male, we have to test the brain and the testes, and we'll come to the tubes later, the various tubes of the male. Now, if the problem is in the brain, then it means that the brain is not instructing the testes to produce sperms. And the levels that we're going to measure the brain is the FSH and the LH, and the testosterone and the prolactin levels. And those will be very low because we need high levels of FSH for sperm production. We need elevated levels of LH for production of testosterone, because you need testosterone for the production of sperms. If the problem is in the testes, the FSH and the LH levels will be high, and the testosterone levels may be low. So by doing the blood test, we can tell if the problem is in the brain or in the testes. If the problem is in the brain, then we can manage these guys. I mean, studies have shown that if we treat these patients with recombinant HCG using Orbital 250 micrograms, a weekly dose, over a period of 12 weeks, the sperm counts increased from 0 to 36 million sperms per mil in a period of 6 weeks, if you use these available drugs. And the testosterone levels also increase significantly in a period of 12 weeks when these patients get a weekly injection of Orbitril. Unfortunately, some of our colleagues don't understand the physiology. They tend to give the patients steroids instead of giving them HCG. And steroids are a big problem and a big no-no in patients with infertility. Then there are plumbing problems which can cause infertility. Now, I'm aware that many folks are not aware that men have got more tubes than women. Women have got one tube on the left and one on the right. We have 3 tubes on each, at least 3 tubes on each side. So there's a high risk that any one of our tubes can get blocked. So we can get problems in the epididymis, which is one of the tubes, in the vas deferens, or the ejaculatory duct. So any one of those tubes can get blocked. Sometimes the sperms get lost. Instead of going to the vagina, they get directed into the bladder. And the guys don't fall pregnant because the sperms have gone to the bladder and not into the vagina. Sometimes the ducts are not there. These guys were born with absent tubes. Or just like with ladies, you can get an infection of these tubes. But if the problem is in the tubes, treatment is available, either through surgery to repair the tubes, or we can bypass the tubes and get the sperms directly from the testes. And getting the sperm directly from the testes is very efficient and very effective. As you can see, that outcomes are very good in these patients. One of the big problems that we see is the abuse of steroids. The guys who take steroids for social reasons, to build muscles. Now, the problem with steroids is this: if you take these steroids intravenously, now these steroids will increase the amount of steroids in the blood. But there's a blood-testis barrier, so these steroids do not go into the testes. These high levels of steroids in the blood will then go to the brain and tell the brain to shut off the production of testosterone in the testes. And if there's no testosterone production in the testes, there will be no sperm production in the testes, because production of sperms relies on androgens, on testosterone. And the levels of testosterone is 200-fold higher in the testes than in the blood. So if you block the production of testosterone in the testes, these guys will not produce sperms. It's a big problem because we cannot give testosterone for infertility if guys want to fall pregnant, because we're going to make them infertile. But there's another problem with using steroids. Steroids make all the muscles of the body to grow, to hypertrophy. And the big problem is in the heart, because the heart has got a particular size. So if the muscles of the heart increase in size, then the space in the heart where the blood should stay gets smaller and smaller. So the muscles get bigger, but the space for the blood gets smaller. And these guys often die suddenly because there isn't enough blood to supply the brain, to supply everywhere else. And it's a problem. You get sudden death from hypertrophic cardiomyopathy. So steroids are bad for fertility. Steroids are bad for your health. So unfortunately, age does count, because men do have a biological clock too. As men get older, there's a dysfunction of the impulses in the brain that control the sperm production. And secondly, as the testes get older, they don't respond well to the messages from the brain. And as we get older, the amount of androgens of testosterone declines. And what this will cause is increased risk of sexual dysfunction. As we get older, we get muscle wasting, we get bone problems, we lose body hair, and we start getting memory loss and stuff like that. So advanced age in male causes increased miscarriages, there's increased stillbirths, there's a higher risk of bipolar disorders, and a number of other medical disorders such as achondroplasia, osteogenesis imperfecta, and Marfan syndrome. Then there's sexual dysfunction as a cause of infertility. Now, patients on chronic medications, whether it is hypertensive medications or diabetes medication, patients who are smoking. Now, smoking impairs the vessels, and erection requires intact blood vessels because it is blood vessels that get engorged. So if they smoke, you don't get that engorgement of the vessels, and these guys get sexual dysfunction. They don't get an erection. Alcohol causes disinhibition of the guys, but it causes sexual dysfunction because the guys can't perform. And various conditions like heart disease and chronic medical conditions can cause sexual dysfunction and infertility as a result of that. So as we conclude our talk, how do we do to fast track our patients to fertility, to parenthood? Well, the fat guys need to shed the excess weight. You need to lose weight, because once you lose weight, there's an improvement in sperm parameters and in sexual function. We have to stop smoking to improve our sperm function. We have to reduce alcohol intake. We need to take the necessary micronutrients and medication. And please remember that we are never too young to seek medical attention. So in conclusion, male infertility is an issue of profound human suffering. It is a serious public health issue. It causes significant physical and emotional impairment. So men must be included in the equation, and men must access available support system. But I'm here to tell you guys that yes, it is still possible to have your family despite everything. Even if you don't have a sperm count of 0, it is still possible to have your family. Thank you very much.
Thank you, Dr. Biko. Thank you. That was very informative. And there are a few questions for you, which we'll go through at the end of our session. Our next speaker is Dr. Michelle Redelinghuys. Dr. Michelle is a fertility medical manager at Merck, and she'll be talking to you about Merck's commitment to patient care.
Thank you, Saskia. Can I just ask Dr. Biko to stop sharing his screen quickly?
I'm trying to do that.
Thank you.
Did I stop?
Not yet.
Not yet.
There you go. Done.
Nope, I think it's still sharing.
No.
Oh, is it? Oh, is it? Okay, wait.
It shouldn't be sharing now. Oh, yeah, so I got it. Yeah.
There you go. Try now,
Super.
Michelle.
Got it. Thank you. I'm going to start us with a little video and then we can go from there.
Perfect.
This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning. Are we curious enough? Could we be closer? Can we? Can you feel it?
Good evening, everyone. And firstly, thank you very much for the opportunity to have a little bit of a chat to you. I'm very excited to actually be here. I'm just quickly going to share my screen. Okay. Just let me know, are you seeing just one big slide, or are you seeing my little notes, my crib notes?
We can see your notes.
Ah, okay, let me switch that around. That better?
Yeah.
Good. We can't have the crib notes showing. So as as you would have seen from the video, one of the mantras that Merck really has is, are we curious enough? And we believe that curiosity is what always drives everything that we do. And that's why we're also so excited to be part of this week. Merck is actually a pharmaceutical company. So we are heavily involved and invested in research and development of novel medications to help patients. And we really believe that if we're innovative, we can help to improve patient lives. And so for us, it's been an absolute pleasure to be able to sponsor the webinar and be involved tonight, because this entire week is in itself innovative. National Infertility Awareness Week is the first of its kind in South Africa that's being hosted by IFAASA and House of Fertility. And really what drives these events is our curiosity to learn more. In addition to being involved in these webinars, Merck is also really invested in terms of patient awareness. And I would like to invite you and encourage you to visit our new website that's actually just been updated. And the reason for that is that this website actually has a lot of interesting features. It's easy to navigate, and it has some information with regard to fertility. You'll see the tab Understanding Infertility actually addresses a lot of what Dr. Biko has spoken about tonight with regard to male infertility. There's also some aspects on female infertility, and also a really nice section in terms of how to approach seeing a fertility specialist, the kind of questions that you should be asking when you're starting on this journey. We've also included a nice section on the psychology of infertility and everything that's associated, the emotional impact, some of the treatment options. And then also, I know there's an entire week of webinars, and it's incredible and informative. If after this week you're still unsure as to whether you should be reaching out to a fertility specialist, we also have a section which is called the Self-Assessment Questionnaire. And a lot of the risk factors that Dr. Biko has spoken about tonight for both men, and then we also have for women, are incorporated into this assessment. So you can actually go through the questions, and at the end you'll actually get a result to say, try a little bit longer, or now is the time to reach out to a healthcare professional and get some further assistance. And then lastly, if you are getting to that point, there's a really nice section on the website as well, which is linked to Google Maps. So you can zoom in on the geographical area where you live, and you'll see that it's actually been divided by province. And if you're outside of the country, we also include Mauritius, Kenya, Uganda, Botswana, etc. And you can find the contact details of accredited fertility clinics near you. And all of these resources are really just available to help you on this journey. So I encourage you to visit the website. It's www.merckfertilityjourney.co.za to learn more and to empower yourself as well. And just on a personal note, I've worked in other fields of medicine within pharma. I joined the fertility team about a year ago at Merck, and I can honestly say it's been some of the most rewarding work that I have ever been involved in. And the reason I say that is that we meet many people along their fertility journey, and often there is some despondency, there's sadness, there's despair, especially in those beginning stages when you're still trying to come to grips with the fact that you or your partner may have fertility issues. But I can also tell you that if you carry on this journey, there is often so much joy and so much hope that actually comes at the end of it, and that's what makes it so, so rewarding. So I hope that wherever you are on this journey, I wish you all the best. And I hope that at the end of the day that you will actually fulfill this need and want of yours to complete your families. And I wish you all the best. So thank you Saskia as well for the opportunity. And that's it from my side.
Thanks, Michelle. And thank you to Merck for being so innovative and for helping patients on their journey, because that's all about education, and that's what we're about, that's what you're about, and that's why we all work so well together. Okay, our final speaker for tonight, before we get to the question and answer session, is Elie Kouaiky. Elie is the co-founder and director of Maybe Mom South Africa, together with his wife Amanda, and he has a personal story of infertility to share with you all. Hi, Elie.
Hi, Saskia. First of all, thank you very much for inviting me on this beautiful, beautiful week. And thank you for all the doctors and the information. It's still quite emotional every time I go through this journey, every time. Perhaps I should start by describing my competence. No, I'm not a doctor or a gynecologist. My qualifications are far more appropriate. I was infertile with my lovely wife for 5 years, hit rock bottom. I was told we couldn't have kids, had the perfect love story before that. And I never forget that day. The day they told me I couldn't have kids, like every man who's listening to us tonight will understand, something inside of you gets broken, gets taken away from you. As Dr. Biko said, that it's more than just babies. Men feel that I felt that my manhood was gone. I'm not a complete man. And tonight, I just want to talk to all the men out there. The one thing I can advise every single man that's sitting and listening over here is that I want to ask you from the bottom of my heart is just change your mindset and the way you approach the infertility journey. You are very much a big part in this. Think about it like that. You walk into a fertility clinic. Just open your eyes and look. 90% of women are reading the flyers and all of that. And what do us men? We sit on the side, we hide our heads, and we're like, I hope the guy next to me doesn't know what's going on with me. I want you to look around you when you are approaching infertility, even if you end up in a fertility clinic. Just look around you. Every single couple that's sitting next to you is going through the exact same thing as you are going through. You are not less than a man if you are going through infertility. You have every right to become a father. You have every right to be a husband, a perfect husband. Infertility, what I've learned in my life, it's a story. It's a special story for every man to stand up and say, you know what? I'm part of this marriage. I want to do this. Walk to fertility clinics, walk in front of your wife. You talk to the doctor. You take control. You find the information because you are a man. You're still a man. You're still the head. She's still the neck. And guys, it's very simple, okay? Just think about it like that. I'm not a doctor. I'm not going to talk to you about the technical side of it. I'm not going to talk to you about what's a good sperm count and what's a bad sperm count. But for me, through my life, it's about a simple thing. Me, you, and everybody around us, we were 1 in 40 million that day. 1 sperm that made it. Don't you sit down and ask yourself why? Why did I make it? If you are not worth it, why did you make it that day? Because there was another 40 million reason why you shouldn't make it that day and you made it. So you are worth it. You are worth every single breath you are taking. Infertility is, for me, after looking at it, my story ended up, well, I had twins. I'm still together with my wife, which if you listen around you, many couples don't make it till the end of their journey in infertility. Many couples, they hit infertility. By the time the kids come, the marriage is broken. You know what? Infertility is not about breaking marriages. It's just an obstacle in our life that we have to go through. And open your heart, open your mind. This is when you get tested for your faith. You get tested because if you change the way you look at things, the things you look at changes. I just want to tell all the men out there, if you are really feeling down, look how many people are here this week. They took out of their time to sit in front of the screen and explain to all of us what is the latest technology. And all these people from IFAASA, they have their personal journey from House of Fertility. We are all guys like you. We just went through infertility. We got hooked to it. We loved it. We loved every single part of it. And we decided at the end, you know what? The best way to heal is to talk about it and to give back. I wish you guys everything of the best from the bottom of my heart. And I just want to remind you that infertility is not the end. It's just the beginning, because in the beginning there was just you and her. It's always been about you and her. It's always been about your partner that's sitting next to you. Don't let the journey destroy you. I wish you guys everything of the best, and that's from my side. Thank you.
Thank you, Elie. I know there's more than one wet eye in the house tonight. That was very powerful. Thank you for sharing your story. It's great for couples to hear that they're not alone, especially from a male's point of view. As you know, females are more likely to go out and find support. So we really, really, really appreciate you telling us your story and you guys being so open about your journey. So thank you.
Thank you.
Okay, now it's time for the question and answer session. Dr. Biko, are you ready? Because these questions are directed at you, and I do apologize about my pronunciation for the medical terms, but I'm not a medical specialist, so that's my excuse. So we're going to start with number one. In terms of alcohol and smoking intake, what is regarded as excessive that could impact the sperm health in a drastic sense?
So smoking is generally bad for fertility. There's no limit as to how little is safe. So smoking is bad. Alcohol, I presume, if you don't get drunk, I suppose, shouldn't be bad. I'm not sure about alcohol. I don't know if any value for alcohol. But smoking per se is really bad for fertility.
Okay, thank you. Then what is the impact of a vasectomy on sperm at a later stage? What supplements and food are recommended to improve sperm quality when planning a pregnancy? Does age play a role in male fertility? That's two questions.
Yeah, so once you had a vasectomy, the only way for the couple to conceive is through ICSI, or if the guys go do a reversal of the vasectomy. Now, studies have shown that if you reverse vasectomy, there is an up to 40% chance of conceiving after reversal of vasectomy. In the past, you used to think that if the vasectomy was done more than 20 years ago, the sperm quality was going to be bad. But current studies do not put a limit to the time frame of which the vasectomy was done. So after vasectomy, we can fall pregnant. The best way is probably through IVF, ICSI, otherwise do surgery to reverse the vasectomy. The second part was?
Does age play a role in male fertility?
Yes. So I'm very sorry about my slides. Apparently the guys didn't see my slides well, but you're probably going to make them available to the guys. Just like in females, age plays a significant impact, on male fertility. So as the guys get older, we get more abnormal sperms, making abnormal babies, increased risk of miscarriage and stillborns and stuff like this. So age has a negative impact on fertility.
Okay, thank you, Dr. Biko. Yes, we will make the slides available, not a problem at all. How will stress affect my fertility? I'm guessing it's coming from a man. Well, I mean, it can affect from female as well. So, but as is male infertility, let's do it from the male version.
So stress will affect the performance. This anxiety, stress, you get anxious, and they become anxious and guys don't perform. So it's a performance thing. In terms of sperm parameters, I haven't seen a study that says that stress causes impaired semen parameters. It causes dysfunction, sexual dysfunction, not sperm abnormalities.
Thank you. Okay, Dr. Biko, my partner has recently been diagnosed with stage 1 varicocele, is that how you pronounce it? Which, as I understand, is a less severe form. He has done 2 sperm analysis and blood tests, and his sperm count is only around 2 million with a motility that is not great. So number 1, can the varicocele be the cause of such low sperm numbers? And number 2, I have read that varicocele repair does not mean it will increase sperm numbers. Yes or no?
Yes. Stage 1 or grade 1 varicocele normally doesn't have such a low values in terms of sperm numbers and morphology, because usually it's very light, it's minimal varicocele. Stage 1 means that this varicocele can only be palpated when the guy is having a Valsalva maneuver. So usually with stage 1 disease, you don't get those bad sperm parameters. So we should not accept that because he has stage 1 varicocele, that is the cause of the abnormal semen parameters. They must look for other factors as well. Secondly, yes, you can take some medications to improve the sperm parameters with stage 1 varicoceles. And having a morphology, a low sperm count of 2 million, I think is that is an indication. If the morphology is low, the sperm count is low, and the motility is low, it might be a good idea for them to go for assisted reproduction instead of waiting for the sperm values to get better. Because I don't know how old she is, I don't know how old he is, because time might not be on their side. So I would recommend that if you're on the older side, rather, instead of taking all the medications, go for ART, because 2 million sperms is good enough to do IVF ICSI.
Thank you. Does HIV and the use of ARVs decrease male fertility? And if so, how?
I don't know the data. What I've seen from our clinic is that the ladies who are HIV positive and on treatment, we get a little bit of a lower pregnancy rate than those who are HIV negative. I don't have the data to specifically say why that happens. So in our clinic, there's a little bit of a lower pregnancy rate in those who are on HIV treatment. The ladies, for the guys, I haven't seen that yet. Not that I've looked, but I haven't really looked on the guys. But on the ladies' side, definitely, there's a lower chance of pregnancy in our clinic. I don't know why.
Thank you. Okay, another question for you, Dr. Biko. Is it true that when a couple is trying for a child, the man has to wait 3 days intervals or so before they can have sex with a woman in order for their sperm to be fully mature to be able to fertilize an egg? Like if my husband and I have sex today, we must wait for at least 3 days to engage again because sperm takes about 3 days to be fully mature. I'm not sure if that makes sense.
No, that's incorrect. So actually it takes about 74 days for a sperm cycle, for a sperm to move from immature to mature. So you could have intercourse every day or every second day or every third day. So what is recommended is that for couples to have intercourse around the time of ovulation, once every 2 to 3 days is enough. You don't have to do it every day, but if you can do it every day, it's fine. There's nothing negative about doing having intercourse every day. But recommendedly, once every 2 to 3 days should be fine as well.
Okay, and are there any recommended supplements and foods to improve sperm quality?
So there are a lot of products available on the market that say that they improve the sperm quality, and they call these products I forgot the name now of them. So the thing is, or antioxidants, so they call them antioxidants. So we have to be careful that too much of a good thing can be bad. So if we take a lot of antioxidants persistently for months, we can change the environment from oxidative stress to reductive stress. So there are a lot of publications which have shown benefit if we use all these products, which these antioxidant products, but there are others which have shown harm. So the current thinking is that whatever product you use, don't use it for more than 6 months, because then beyond 6 months, the harm outweighs the benefit. So the products that you're going to be using, don't use them for more than 6 months, otherwise you're going to be in trouble. So they do work if there's oxidative stress, but there are tests that can be done to see if the problem is oxidative stress or reductive stress on the sperm. So the tests are available. Then you can give the guy the correct treatment instead of just guessing.
Thank you. Elie, there's a question for you. Thank you for sharing your story. How did this affect your marriage?
Okay, guys, for all the guys out there, to affect our marriage is very simple. Intercourse becomes a job. Every time our spouses touch us, we have this idea in our head that it's just for babies, it's not for us anymore. So the love and the passion and the endorphins start getting depleted. We start feeling disconnected. We start feeling used as men. And you know what? This is where you have to put your foot down, and you got to take these ideas out of your head, and you got to calm your partner down. You got to set her down. You got to talk to her. You got to tell her that you are with her in this journey. And the essence of the journey is you and her. That's how it affected us. It took the love out of our relationship. And sex shouldn't be a job. Sex is an outcome of our love to each other. That's how we express it physically. So don't forget that it's a very, very important aspect of marriage. At any time you feel that you are getting disconnected with your partner and you are drifting away from them, this is the time. You put your foot down, you sit down with your partner, you have an open conversation, you go back to, to have fun again, open a bottle of wine. I know now alcohol is not permitted, but do something you haven't done before and have fun, guys, because you're worth it. And I'm here for you. You can connect with me on Facebook, on Instagram, anytime you want. You can send me an email. I will answer any question you want. I can assist you in any way I can. Okay, and that's my answer. Thank you.
Thank you, Elie. And somebody else has said, thank you very much. You said everything my partner needed to hear. So thank you for that. Okay, we're going to be wrapping it up shortly. I'll give Dr. Biko another couple of questions. But if we don't get to your questions in the session, please feel free to email them to me and I'll pass them on to Dr. Biko for his reply. It's Saskia at IFAASA, IFAASA.co.za. Okay, and the video will be available tomorrow on the IFAASA YouTube channel as well. And I'll attach Dr. Biko's slides to that upload. Okay, Dr. Biko. All right, let's do this one. What treatments can be followed to improve morphology, currently at 2%?
So when you check the sperm parameters, it is important that you don't choose one particular thing. 2% of what? So what is the sperm count? So if the sperm count is 15 million, we say that if it's 15 million per male, and the morphology is 4% of that 15 million, that's what we want. That's what we call is normal. So if it is 2% of 100 million, the 2% of 100 million is more than the 4% of 15 million. So one should interpret the whole sperm count together, not individually. So I can't comment on the 2% of a morphology when I don't know what is the total sperm count there. So I need to know all of those kind of situations for me to make a comment about this.
Okay. And then the second part of that same question was, have had 2 failed IUIs, progressive motile morphology and vitality are below reference value. What is your recommended treatment? Should we continue with IUI or should we move to IVF ICSI?
So the guidelines generally we apply in South Africa is that you try 3 cycles of IUI if everything is fine, and then if it doesn't work, you go to IVF. However, if there are other problems like a low sperm count or something, we'd rather go to IVF quicker than 3 cycles. And also your age determines where we go to. The recommendations from the USA is that if you are beyond the age of 38, it might be better to go straight to IVF instead of spending time on IUI, because it's not only about the cost of the processes, but it is the effect of having a negative test. IUI success rate is what, 15%, and you have to do it so many times, and every time you see a periods, it causes severe stress to our patients. So if you've tried it twice with those low counts, rather go straight for ART.
Thank you. And then we'll do one final question, and the rest, please, can you email them to me? And obviously we'll keep it anonymous, etc. I'll get the answers from Dr. Biko and I'll email you back myself. Okay. Let's see. We're struggling with secondary infertility, male factor. I have an underactive thyroid and my husband has tetrazoospermia. Which do you think will work best, IVF or ICSI? It's a similar question for us. And how many cycles do you think we need to budget for?
Okay, fix the thyroid. Let's fix the thyroid, because if it's underactive, it makes fertility difficult. And if you do fall pregnant, it's going to be a difficult pregnancy. It can affect the baby as well. It can have an abnormal baby. So the thyroid must be fixed. Once that is sorted out, then we can decide, depending on the values of the sperm parameters, that whether we should do IVF, ICSI, or IUI. So the thyroid problem must be fixed before anything else can be done.
Perfect. Thank you, Dr. Biko. And I want to thank all the attendees for joining us and taking charge of your fertility. Tomorrow we're going to be talking about female infertility, focusing on PCOS and endometriosis. If you don't manage to get a spot, if the webinar is full, you can catch it on our YouTube channel on Thursday. Today's video will be uploaded tomorrow as well, as mentioned before. I'd like to thank our sponsors, Merck, and our headline sponsors for the week, 360 Biomedicine. But the biggest thank you of all must go to Dr. Biko, to Dr. Michelle, and to Elie for giving of your time, your expertise, and your personal journey tonight. We really do appreciate it. And I know that you've all helped somebody out there and made their journey a little easier. So thank you very much. Thank you for everything. Take care, everyone, and keep safe. Bye.